Hello, good evening, everyone. So, welcome to this recall session for medicine questions in the NEET PG 2025. I'm Dr. Srinath, your medicine faculty. So, I'll be going through the questions. Few specific questions related to respiratory. Dr. Bharat will be also discussing it parallelly. So, let us start with the first set of questions. So, always let us start with the heart first, cardiology. Hannah, since many years, like since when we were students also, there used to be exams when the examiner used to ask multiple questions from the same topic. मतलब कभी कभी by chance you have left one topic for an option और पता चला कि दो तीन क्वेश्चन उसी से आ गए. So it happens sometime. So years have passed, but examiners have remained the same thought process. So this exam had many questions from atrial fibrillation, many questions from Addison's disease, and similar approach to acidosis. But nonetheless, I'm sure that all these three topics, none of you have left in the option because these are all very frequently asked topic. Atrial fibrillation, must know topic, and I'm sure you have done correctly in the initial few questions. So cardiology may, even though in practice, coronary disease, hypertension are more common, we have always elaborated in class that arrhythmias remain a very high yield topic in the exams. So starting with the first two questions in the exam, that a patient presents to the emergency with the palpitation and breathlessness that started 4 hours ago. On examination, the patient is found to have irregular pulse. So we know that when patient has got irregular pulse, we have discussed this, there can be three differential diagnoses. Irregular pulse indicates that there is some kind of arrhythmias. But among the arrhythmias, this type of irregular pulse can be found in patient with the second degree AV block, can be found in ventricular premature complex, and patient with atrial fibrillation. But out of them, yes, correct. So out of these two, the palpitation is an important history that has come. So AV block becomes unlikely. VPC also can come with palpitation, but breathlessness is uncommon in this disease because VPC we have discussed is majority age related, incidental diagnosis more often than not. So best single possibility when patient has come with breathlessness, we are thinking of atrial fibrillation. Now, the 4-hour duration indicates that the patient is not already in shock. If patient was in shock, patient would have been rushed to the casualty. So it is telling you that the 4-hour history is telling you that it is likely to be a stable patient with atrial fibrillation. Means not an emergency. Patient is relatively stable patient with the atrial fibrillation. In this patient, the most appropriate initial treatment, we have learned that in a stable atrial fibrillation, you can go for either the rate control or you can go for rhythm control. But among the two, when the patient is a typically elderly person, and there are no known causes like in this condition, that because of the safer choice, you will always prefer rate control more than the rhythm control. So in this patient, we don't have to do emergency cardioversion because patient is not in shock. Breathlessness is a symptom of heart failure, not of shock. So unless patient in shock, no need for doing the cardioversion. Unless embolization is there, no need to look for the left atrial thrombus, and anticoagulation occurs later. Anticoagulation to prevent the risk of thromboembolism will occur later. So the best answer would be to initiate rate control, and the best drug always would be beta blockers. Majority patient of atrial fibrillation are elderly patient. beta blockers offer a safe and effective way to control the heart rate, which has got equal survival benefit as the rhythm control also. Right? So take it forward to the next question. When a 64-year-old male who has presented with the sudden onset aphasia. So listen importantly when you read about the stroke and the need for thrombolysis. Thrombolysis is considered only when the patient has got a significant neurodeficit. There has to be a significant neurodeficit. So NIHS score is there. So significant neurodeficit. So patient is having aphasia, very important, higher mental function, along with the right-sided weakness is there. So this is important because aphasia indicates dominant hemisphere lesion. There is a dominant hemisphere lesion is present in this patient. Same finding, patient is having irregular pulse. So likely to be a thromboembolic stroke. Likely to be thromboembolism secondary to atrial fibrillation. In this case, the CT scan is normal, and since they have come within the 4.5-hour window period, patient has come early within the 4.5-hour window period, and if the CT excludes hemorrhage, once the CT scan excludes the bleed, you want to proceed with the thrombolytic therapy, and the most approved drug is the intravenous TPA, that is recombinant TPA or alteplase should be the given choice. So we can give tenecteplase also, but best choice remains intravenous tissue plasminogen activator. So to search for the source of the thrombus, to search for the source of the embolus can be done later. Irrespectively, we know that indication for anticoagulation depends upon the Chad-Vasc score in a patient with atrial fibrillation. So to identify the source, echocardiography can be done later. Low molecular weight heparin, not really the correct answer. Carotid Doppler also to search for the source, we can be done later. If the patient had come later after the 4.5-hour window period, then we would have looked at alternative management protocols, right? So answer again is administration of TPA, that is thrombolysis. When a patient presents with fatigue and chronic breathlessness, so innumerable times you have discussed in class, the most common symptom of mitral stenosis, most common symptom of mitral stenosis is the fatigue which occurs due to the right ventricular hypertrophy or right ventricular strain. So the most common earliest symptom of mitral stenosis comes from the fatigue due to right ventricular strain. Patient on examination has a left parasternal heave and opening snap with a mid-diastolic murmur is present. So in the patient with mitral stenosis, the commonest arrhythmia again is the atrial fibrillation. So what are the findings in mitral stenosis? The mitral stenosis person, we always read, can present with a mid-diastolic murmur with or without opening snap. But it is the presence of the pre-systolic accentuation. The pre-systolic accentuation is the hallmark of mitral stenosis patient. But this pre-systolic accentuation occurs due to atrial contraction. Due to the atrial contraction, which is becoming ineffective in atrial fibrillation. This atrial contraction has become ineffective in a patient with atrial fibrillation. And that is why, even though it is a hallmark of MS, this does not occur in a patient with atrial fibrillation. Once the patient has got atrial fibrillation, there will be absent A wave on the JVP. There is increased risk of stroke. There is right ventricular hypertrophy, and there can also be never S4. We have studied never S4. Even if patient is in chronic heart failure, S4 can never occur in atrial fibrillation because of ineffective atrial contraction. That is why the reason is the option number A. This cannot occur even though the disease is valvular mitral stenosis. Take this forward. A patient presents to emergency with chest discomfort and palpitation. The ECG shows PSVT. I think this is one of the easiest questions. The most suitable agent for prevention, we have studied. For prevention, you can give class 4 and the class 2 agent, beta blocker, can be considered. Class 4, that is non-dihydropyridine group of calcium channel blocker and beta blocker can be considered for prevention. But we also said they are only palliative measures. They are not going to cure. They are only palliative measures. So instead of the suitable agent out of the option, if they had asked you that what is the best long-term treatment, the best long-term cure would have been radio frequency ablation of the accessory pathway. Radio frequency ablation would have offered best success rate. But since we are asking from the given option, lidocaine belongs to which class of antiarrhythmic drugs? Class 1B, which are least potent. I have told you again and again that class 1B no longer used in the patient with PSVT, whether it is lignocaine or maxilatin. We have discussed specifically 1B no longer given in PSVT. Nifedipine, of course, not for this. It is used for vasospasm conditions, and adenosine is the drug of choice for acute PSVT, not for prophylaxis. For acute cases, we can definitely give adenosine, but not for the prophylaxis. So it has got tender hepatomegaly also present. So Preeti, that are only suggesting, if it is there, that is only suggesting right heart failure. Tender hepatomegaly only is indicating right heart failure. So it does not make any difference in this question. Okay. So is it of the previous question you are talking? Maybe. Even if you think that it is a tricuspid stenosis. Okay. If you are looking at a tricuspid stenosis also, it is the irregular pulse that is important. Once atrial fibrillation comes, pre-systolic accentuation will go irrespective of the lesion. I got that. Yes. So which of the following? Okay. So options oral phenytoin and the oral. So even if you look at oral phenytoin is responsible. It is the class 1A agent, potent, but for only acute attack only. The second one, IV ismolol. So we have discussed this. IV ismolol is used in the hypertensive emergency when the patient comes with aortic dissection. The only indication of IV esmolol is the IV dissection, aortic dissection, hypertensive, the emergency. We can give the esmolol, right? So options were oral phenytoin. So which one was not there? No defendipine, no lignocaine. Fine. So similar explanation can be done. Yes. So thank you so much for filling the gaps. Which of the following crystalloid infusion, when given in large quantity, can lead to hyperchlormic acidosis? So the clear answer is normal saline. The normal saline or the 0.9% NaCl contains a large quantity of chloride. So the presence of chloride in the IV fluid the presence of chloride, negative charge in the IV fluid enters into plasma. Plasma has to maintain electroneutrality, causes hyperchloremia. It causes hyperchloremia, which causes the bicarbonate shift intracellularly, bicarbonate shift into the cells, leading to acidosis also. That is why we say it can lead to hyperchloremic acidosis can occur. This is because of the concept we have discussed. Plasma has to maintain electroneutrality. Negative charge will always be equal to positive charge present in the plasma. That is why NS large quantity can lead to this adverse reaction. Next one, APG question that you know. So when the pH is 7.22, pH is going down, indicating primary defect is acidosis. Second, the bicarbonate is 16, also going down, same direction. So primary defect is metabolic acidosis. That is sure. In this metabolic acidosis, we want to calculate the anion gap. So anion gap can be calculated here. So we already have the sodium value is here. We have got the chloride value and we have got the bicarbonate value. So anion gap is equal to sodium minus the chloride plus the bicarbonate is there. So that is 130 minus 16 plus 84. So that is equal to 30 milli equivalent. So it is a high anion gap metabolic acidosis was the diagnosis probably hinted in the question. Right? So simple calculation was there, not much difficult. The second one, even more easy. When the pH is 7.20, that is again going down, indicating primary defect is acidosis. CO2 is 66 going up, indicating opposite side defect is the respiratory acidosis. Bicarbonate remains normal, indicating no compensation is present. If no compensation is there, it indicates it is an acute defect. There was no time for compensation. That would include an acute defect, but that was not asked in the question. They were asking you only what is the primary defect. As we have discussed in the class and in the practice MCQ, this can be replaced by respiratory, acute and chronic also. So this case would have been a case of acute respiratory acidosis would be the single best answer for this question. Taking this forward, when a lady presents with weakness in her right hand and she finds difficulty in kneading the floor. So basically there is small muscle weakness with atrophy of the right arm and forearm muscle. So when there is atrophy of the small muscles, atrophy of the small muscles of the hand indicates lower motor neuron lesion. Also there is decreased deep tendon reflex, which also favors LMF. So this type of finding, typical finding atrophy of small muscles is typically found in motor neuron disease. Typically found in patient with motor neuron disease. Sometime rarely syringomyelia, but motor neuron disease is lesion of the anterior horn cell lesion. Typically found in motor neuron disease, seen in the anterior horn cell lesion. Because all these are upper motor neuron disease. All these cortex, pyramid and internal capsule are all upper motor neuron, where you will have get spasticity with exaggerated deep tendon reflexes. So take that forward here. When a 68-year-old male with type 2 diabetes and a HbA1c of 8.1 was being evaluated. So patient is having uncontrolled diabetes. We want the HbA1c to be controlled, less than 7 ideally. Patient also is having chronic heart failure with the ejection fraction less than the 40. So less than 40, EF less than 40 is called reduced ejection fraction. In the patient heart failure with reduced ejection fraction, what are we recommending? We are recommending quadruple regimen. The quadruple drug treatment should include valsartan plus secubitril combination ARB plus neprilysin inhibitor, that is secubitril neprilysin inhibitor is there, along with the cardioselective beta blocker, along with the mineralocorticoid receptor antagonist, and the SGLT2 inhibitors are recommended in the quadruple drug therapy. So valsartan and neprilysin inhibitor, beta blocker, mineralocorticoid receptor, eplerenone, aldosterone जैसा inhibitor, and SGLT2 inhibitor, empagliflozin, is going to be the correct answer. We have discussed this, that this SGLT2 inhibitor has got the pleiotropic action. It protects the vascular endothelium, and that is why it has become one of the approved drug in both. It is approved in both the chronic kidney disease and in heart failure, even in the non-diabetic patient also. Even in the non-diabetic patient also, my answer would still be to give SGLT2 inhibitor in this patient. Now already patient is diabetic uncontrolled, then the best drug to add will be SGLT2 inhibitors. When a 60-year-old male who presents with established CKD having worsening exertional dyspnea is there, fatigue and heart failure is there, investigation reveals severe anemia is present, what would be the best treatment? So if no details are given, statistically we know most common cause of anemia in the CKD, most common cause of anemia in the CKD is the erythropoietin deficiency. So in the absence of detail about the iron store, the best treatment would be to put the patient on erythropoietin. So if they had mentioned that the iron store, that is transferrin saturation, if they had mentioned that the transferrin saturation is low, or they had mentioned that it was a microcytic type of anemia, then probably I would have considered IV iron would have been my first choice. But when they ask you corrective, only giving IV iron, not enough for CKD patient. You have to go for erythropoietin supplement. Without that, you cannot replace. Also remember, when we give IV iron, one of the important side effect of IV iron, it can cause increased blood pressure. Transiently though, but it can cause transient increase in the blood pressure can occur, which may sometimes affect the heart failure adversely. So we have to go stepwise only. Correct answer, darbepoetin. When a patient with type 1 diabetes presents with a blood glucose level of 720, we know we are talking about diabetic ketoacidosis. In diabetic ketoacidosis, along with giving IV insulin, because the only contraindication to IV insulin is hypokalemia below 3.1 milliequivalent or 3.3 sometime, and you want to give hydration with isotonic fluid. Isotonic fluid like normal saline should be given, but what is not given in the part is 3% saline. So even though the patient has got hyponatremia, this hyponatremia is not because of the sodium, but it is a technical error. It is a technical error due to high glucose level. Due to high glucose level, sugar level in the blood. So for whenever the blood sugar becomes more than 250, for every 50 milligram rise, so when the blood sugar level becomes more than 450, for every, more than 250, for every 50 milligram rise in the blood sugar level, the sodium level can drop by 1 to 2 milliequivalent. So there can be a technically false lowering of the sodium that is there. So don't have to give 3% saline. You want to give only IV insulin with potassium monitoring and replacement with isotonic fluid. Done. Take this forward. When a patient presents with salt craving means hyponatremia is there, but there is hyperkalemia, metabolic acidosis, which indicates aldosterone defect also is present. With the skin pigmentation, we are likely to talk about Addison's. Addison's disease is both glucocorticoid and mineralocorticoid deficiency. It is both glucocorticoid and mineralocorticoid deficiency is present. So these features are typical of the Addison's disease. Hyperaldosteronism. Hyperaldosteronism. In hyperaldosteronism, we have studied with channelopathy. They come with hypokalemic metabolic alkalosis. Hypokalemic metabolic alkalosis can be present. Right? So correct answer, Addison's disease. In the patient with Addison's disease, what is the reason for skin pigmentation? That we know, elevated ACTH level. ACTH is coming from the pre-opiomelanocortin. Pre-opiomelanocortin is the precursor of the ACTH. So along with release of ACTH, there is also release of melatonin, which is responsible for the skin pigmentation. One of the very common questions asked, that skin pigmentation, where it can occur? The skin pigmentation can occur everywhere in the body, can occur everywhere in the body, except over the moles, the scars and the birthmarks. Except the moles, the scars and the birthmark. Except that hyperpigmentation can be seen everywhere around. Take this forward now. When a 26-year-old male presented with the back pain, which was more in the morning, relieved with exercise. इतना खुशी हुआ मुझे ये पढ़ के, है ना, rheumatology. Every one of you know that inflammatory arthritis, which is axial dominant in a young male, उसमें कोई doubt ही नहीं है. This is ankylosing spondylitis. Patient is a young male. Rheumatology was verbatim from the notes. Anterior uveitis is there, and there is inflammatory arthritis, which is axial dominant. Inflammatory axial dominant arthritis is present. This is typical presentation of angstpon. In this patient, the X-ray showed that sacroiliac joint was normal. But the most sensitive method is the MRI. The most sensitive test to detect sacroiliitis is the MRI. And I keep telling how it is. The sacroiliitis is always bilateral. It may be asymmetrical, but it will always be bilateral. Sacroiliitis is present, which may be asymmetrical, means right more than left, left more than right. But it will always be both SI joint involved, because unilateral involvement always favors tuberculosis. Unilateral involvement will favor tuberculosis will be present, right? So take it from there further. So I was little disappointed that nephrology questions were little less in this exam, but chalo koi baat nahi. We have to be, satisfied with what we get. So patient with altered sensorium with a serum sodium level of 94 was started on 3% normal saline and sodium increased. So what are we suspecting? Osmotic disequilibrium syndrome. Osmotic disequilibrium syndrome can present with the pontine myelinosis causing quadriparesis. Pontine myelinosis, which can be seen with the rapid correction of the sodium. Ideally, sodium correction should be less than up to 10 milliequivalent per 24 hours. If the correction is more, then we are likely to get pontine myelinosis, which can be detected again on the MRI of the brain. We don't need biopsy. We can look for that in MRI of the brain. Helps to detect this pathology. Unfortunately, the recovery rates are very poor. The best treatment would have been prevention. You could have monitored better because there is no other way that we are going to improve the outcome. So take that further. When a patient presents with peripheral neuropathy, subacute combined degeneration, ileal resection, MCV more than equal to 110 is the megaloblastic anemia. Megaloblast or macrocytic anemia with subacute combined degeneration is the B12 deficiency. So you only tell me after ileal resection, folic acid deficiency, not common. Okay, it is the B12 deficiency which can cause this finding. Posterior column involvement. Okay, subacute anterior. So rather posterior involvement, anterior involvement. So subacute anterior, subacute cord degeneration. So posterior column plus corticospinal tract involvement is there. Patient comes with morning stiffness, test positive for anti-CCP. We are talking about rheumatoid arthritis. और क्या चाहिए? हमने तो picture बनाया था. Most specific, they come with our synovial inflammation and pannus formation, right? So we had written also that normal joint in rheumatoid arthritis, what is going to get affected? The first patient is going to get synovitis. After the synovitis, if left untreated, then what is there towards the end of the bone? Cartilage is there. Cartilage erosions can develop pannus formation, and then it would have gone into bone erosions can occur. So typical progression of rheumatoid arthritis from synovitis to pannus formation to bone erosions. We are going to get this pathology typical of rheumatoid arthritis. So this bar nephrology replaced by rheumatology question. The patient present with skin tightening and anti-topoisomerase positive. So patient is having the systemic sclerosis. I keep repeating. वो हमने चार्ट बनाया था ना, comparison between SLE, scleroderma and Sicca syndrome. The most common symptom is always going to be Raynaud's phenomenon. The most common but non-specific, is going to be Raynaud's phenomena in both of them. Interstitial lung disease, calcinosis cutis can occur. The gastric enteral, watermelon stomach, this is a very rare finding. Watermelon stomach, this is a very rare finding in this point. Okay, chalo, ठीक है. Myositis था, Raynaud's phenomena was in the option, or what was there? Myositis was there. So just help me with this. Right. So Raynaud's नहीं, myositis था. So myositis syndrome. Myositis is not commonly associated. So we are looking at, okay, myositis was there. So what else? What did you choose as the best single answer? If not that, then you have to mark the skin manifestation. ये नहीं तो you mark the skin manifestation of the disease. Yeah. Then you have to take it like that. स्किन मैनिफेस्टेशन नहीं, बट कैल्सिनोसिस क्यूटिस ये तो मोर फेवर्स क्रेस्ट सिंड्रोम. वेरी गुड. Most favors crest syndrome. So correct answer would become ILD. Correct. Would be the correct answer. If Raynaud's was not there, then organ involvement, most common organ involvement would have been the interstitial lung disease. Dr. Daksh, yes, you are right. Dr. Divya Kumar, yes, they had asked for most characteristic phenomena. Okay. So common or characteristic hai. So answer remains ILD. ILD would have been the answer. Gastric antral ectasia is not only rare but also non-specific. So answer would remain interstitial lung disease only. Chaliye. So when a 14-year-old person had rapid growth, coarse facial feature, what do they want more? For acromegaly, what is confirmatory test? Is to go for the growth hormone level, growth hormone suppression test. So inability to suppress the growth hormone. So inability to suppress the growth hormone after glucose tolerance test. So growth hormone suppression test would have been the most appropriate answer, right? Growth hormone suppression test. When a middle-aged adult presents with knee swelling and pain, synovial fluid shows rhomboid crystal with positive birefringence. आगे पढ़ना भी नहीं, answer pseudo gout है, and we can go further. Yes, correct, you are all. बराबर चल रहा है आपका. So I hope all of you have got most of your medicines correct. Asthma question, Dr. Bharat will discuss more. So patient is taking LABA and the tiotropium LAMA patient is taking, which is anyway not the best choice. Best choice for bronchial asthma would have been to start the patient on ICS with LABA inhaler. Okay. Best treatment here would have been ICS with LABA inhaler. But you can again look for Dr. Bharat's video also, which will follow soon. So, patient of migraine started on sumatriptan, that is for the acute attack. Patient is taking, develops chest tightness when she takes the drug. And patient had family history of coronary disease. What will you give? Propranolol. So beta blocker can relieve this spastic condition and help feel better because there is a pain causes cardiac neurosis. I would want to give the propranolol. That is correct answer. So this also one question from nephrology, 12-year CKD patient. I'm sure pediatric वालों ने छीन लिया होगा, but कोई बात नहीं. We'll also take it. So hypocalcemia is present. There is hyperphosphatemia is present, and there is elevated PTH. You must never treat only calcium alone, because if you do that, then this can cause endothelial damage leading to risk of heart failure. So correct answer, as most of you told me, yes sir. So इस क्वेश्चन का कंफ्यूजन है, वो पीटीएच एलिवेटेड था नहीं था ये सोच चल रही है, बट फिर भी सीकेडी पेशेंट में जो भी होगा, कैल्शियम अकेला कभी नहीं देना. कैल्शियम अकेले देने से फॉस्फेट रह जाएगा, दैट विल कंटिन्यू द प्रोग्रेशन ऑफ वेस्कुलर डैमेज. आंसर फर्स्ट लाइन ट्रीटमेंट ऑफ सीकेडी हमने बार बार पढ़ा. जब भी बोन डिजीज है, फर्स्ट लाइन ट्रीटमेंट इज टू करेक्ट मिनरल होमियोस्टेसिस. ये करेक्ट आंसर हमेशा ये होगा. To correct the mineral homeostasis will always be single best answer in this point. Yes. So see, cholecalciferol alone will not reduce PTH. PTH is increased as a response to secondary hyperparathyroidism. So by giving calcium and D3, yes, you will be able to increase the calcium and reduce the PTH. But what remains unsolved is the elevated phosphate. What remains unsolved is elevated phosphate, which is almost invariably present in a patient of CKD. So when a 35-year-old presents with progressive dysphagia, regurgitation, bronchiectasis due to chronic recurrent aspiration leading to bronchiectasis, with a rat tail appearance on the barium swallow. It is typical of the achalasia. This achalasia cardia best diagnosed on the manometry, achalasia cardia to measure on the barometry. Yes. So phosphate binders with calciferol, है ना? ऐसा नहीं होता ना, चॉइस में नहीं होता, कैल्शियम तो देना ही है आपको. सो आई नो सम वेरिएशंस आपको लग सकता है, बट अभी के लिए कैल्शियम विथ फॉस्फेट रिमेन्स बेस्ट सिंगल आंसर. चलिए, so here we are looking at the esophageal manometry. ये लास्ट क्वेश्चन ऑल्सो मुझे जस्ट हेल्प करना कि ये एक क्वेश्चन था, यंग फीमेल प्रेजेंटेड विद जॉन्डिस, एंटी माइटोकॉन्ड्रियल एंटीबॉडी पॉजिटिव, प्राइमरी biliary cholangitis. Yeah, any modification in this answer, let me know. So anti mitochondrial antibody positive, डॉक्टर अरविंद सर ने तो बोल दिया बस छोड़ दो, आगे पढ़ना भी नहीं है. आंसर प्राइमरी biliary cholangitis. Done. So these were our medical recall questions. There are few questions from ARDS and sarcoidosis which our person, Dr. Bharat, will discuss. So Dr. Divya, I know it was achalasia, but weight loss, yes, you were going to think. Glove and stocking, yes, glove and stocking is bilateral distal neuropathy. Bilateral distal neuropathy. Yeah. So that is correct one. Yes, bilateral symmetrical neuropathy is most common in diabetes. राइट. सो इसको मैं ऐड कर देता हूं. बायोप्सी ऐड किया है. सार्कोइडोसिस दैट यू विल डू इन रेस्पिरेटरी क्लास. चलो, ओके. सो ऑल द बेस्ट. टाइम फॉर यू ऑल टू एंजॉय योर ब्रेक टिल द रिजल्ट्स कम. सो बहुत ज्यादा स्ट्रेस नहीं लेना, अलग कुछ आगे पीछे होगा. If there are some difficulties, difficult question, everybody must have found it difficult. So sit back, relax, enjoy the time, wait for the results, and keep becoming focused on becoming good doctor, right? Automatically theory will follow. Chalo, all the best to you.